So a very good afternoon to everyone. I would like to thank everyone who has joined this afternoon for this important webinar on pediatric ependymoma. And I would like to welcome our speaker today, who is Dr. Santhosh Upadhyay. So this event is being organized on behalf of Sir Gangaram Hospital and Indian Society of Neuro-Oncology. Dr. Santhosh Upadhyay is visiting Gangaram Hospital for today, and he's had a busy day with seeing all the patients, neuro-oncology ward rounds, neuro-oncology outpatients, and he gave a lecture this morning in Gangaram Hospital on low-grade glioma, and we have somehow convinced him to give another lecture on a very important topic of pediatric ependymoma. So I'll introduce the speaker first. Dr. Santhosh Upadhyay completed his medical school from KMC Manipal, from KMC Mangalore, and then he was assistant professor in KMC Manipal, where I had the opportunity of working with him as a colleague. So he was assistant professor in Unit 2, and I was assistant professor in Unit 1. And we had a good camaraderie at that time. And little did we know that both of us will be in pediatric oncology. And one day he'll be visiting Delhi and, giving this lecture. So it's a big honor for me. He moved to US in 2009 and did his residency at St. John Hospital, and then did a neuro-oncology training from University of Michigan. He joined a neuro-oncology program at St. Jude's and became a faculty there in neuro-oncology in July 2016. He's currently assistant professor of pediatrics at the University of Tennessee and an assistant member in the Department of Oncology at St. Jude, Memphis. His main focus is pediatric ependymoma and atypical teratoid rhabdoid tumor. And his research mainly focuses on the application of genetic and molecular advances in formulating clinical trials aimed at improving the survival of these patients. So I welcome Santhosh today for this talk. I also like to welcome our chairpersons, Dr. Poorna Kurkure. Poorna Kurkure ma'am is, as we all know, is from Tata Memorial Hospital and now the head of Narayan Hridayalaya in Mumbai. And madam has, done a lot of work on pediatric solid tumors and pediatric brain tumors. And also she is the one who was responsible for setting up the after completion of therapy program at the prestigious Tata Hospital. Dr. Tejpal Gupta is the head of the radiation oncology services at Tata Hospital. And, sir has been really kind and has liaised with the pediatric oncology team all the time to, further the knowledge and the science behind pediatric brain tumors. So I welcome our chairpersons, Poorna ma'am and Tejpal sir. Dr. Anupam is not able to join because of some health reasons. And, he has just conveyed his regards to all of us, and especially to Dr. Santhosh. So without much ado, I think we'll start our webinar on pediatric ependymoma, and over to Dr. Santhosh.
Thank you, Manas, for those kind words, and thank you everyone for joining in today. I know you all are super busy, but taking time out and joining for this webinar, so thank you very much. I hope you can see my screen very well. Some of the things that I'm going to talk today will be similar to what many of you may have heard in the SIOP Asia conference, where I gave a similar talk on the role of chemotherapy in pediatric ependymoma. So there will be a little bit of overlap, so please bear with me. So I do have a conflict of interest here. I, along with Dr. Christopher Tinkle, who's the radiation oncology faculty at St. Jude, we are the co-authors of the ependymoma topic in UpToDate. Since UpToDate is a paid subscription, we do get royalties from this topic from each year from the subscription. So that's my disclosure. And I will be using some of the material from UpToDate towards the end of my talk. So briefly, an overview. What I'm hoping to cover today is primarily the clinical aspects of ependymoma, but I will talk a little bit about the molecular classification and the biology of this tumor, followed by treatment recommendations for newly diagnosed ependymomas, and then maybe then a little bit on recurrent ependymoma. So as we all know, ependymoma is the third most common malignant pediatric brain tumor following medulloblastoma and high-grade glioma. It is, though, however, the most common intramedullary spinal cord tumor in children. The annual incidence in the United States is approximately about 200 cases. So it's not a very common tumor as compared to the adult arena, which obviously brings less attention to this tumor and less funding. It constitutes about 5 to 10% of all intracranial tumors in children up to the age of 19 years, but at about 20% of the spinal cord tumors. The location among in pediatrics, the intracranial location is the most common site of these tumors, with about 90% of the cases seen in the brain and the remaining 10% in the spinal cord. Among this, posterior fossa or the infratentorial area is the most common site, with about 75 to 80% of all intracranial cases, and the rest is seen in the supratentorial brain. It's predominantly a disease of childhood, but can be seen in adults as well, with a median age of presentation between 3 to 5 years and a slightly higher incidence in males. It's most often sporadic in occurrence, but keep an eye out for those rare NF2 patients who will develop spinal cord ependymomas, and hence screening for spinal cord ependymomas is required in these patients. Now, depending upon the location, these tumors have unique imaging features. And the classic posterior fossa tumor is often a fourth ventricle tumor filling up the fourth ventricle, and sometimes with a tongue-like extension, as you will see in this figure, into the cervicomedullary junction. They don't enhance with contrast a whole lot, but of course diffuse with diffusion restricting images. They do restrict diffusion, and so that's one of the features of this tumor, since it's a high-grade tumor and a compact tumor. Whereas in the supratentorial area, these tumors are often cystic in appearance with nodular components as well. The less common myxopapillary ependymoma, which is common in the spinal cord, is often seen in the lumbosacral area, as you see in this figure, filling up the thecal sac. I will not be talking about spinal cord myxopapillary ependymomas today. I'll restrict my talk to the more classic ependymomas. So in 2016, the WHO put out an update to its fourth edition from 2007, where it partially integrated the molecular features into the histology of these tumors and came out with a new classification, as you will see in this slide. In that classification, the myxopapillary ependymomas were classified as grade 1. Now we know that myxopapillary ependymomas in pediatrics tend to behave a little differently than in adults and often requiring treatment modalities, and hence it has been reclassified as grade 2 as per the WHO CNS5 classification, which I'll talk about in a little bit. Ependymomas were also classified as grade 2 and grade 3 in that classification, depending upon the histological features. But certain molecular features like the relay fusion positivity was also integrated, and ependymoma supratentorial relay fused tumors were classified separately. And these could be either grade 2 or grade 3. Now, the most recent classification, which came out a couple of months ago, which is the fifth edition of the WHO classification of brain tumors, it has tried to simplify it a little bit more further, in the sense the histology is no longer, the histological grading is no longer seen as relevant. And as some of us know in this audience, as some of us know that the histology, classifying the histology into grade 2 and grade 3 is not always easy, and it's very subjective. And moreover, it was determined that molecular features tend to override the histology histology of grade 2 and grade 3. And hence, the WHO has done away with classifying these tumors as classic ependymoma and anaplastic ependymoma. And I'm sure much to the relief of the pathologist. Instead, these tumors are now being classified partially as with an integration of molecular features, as you will see in this slide. In the supratentorial compartment, you have the supratentorial ependymoma, which lacks any other molecular features as a separate entity. And then you have two other classifications which we are familiar from before, which is the relay fusion positive, which has been now renamed as the ZFTA fusion positive. And I'll come to this in a short while. And then you have the YAP fusion positive as before. So you have the supratentorial ependymoma, YAP fusion, and ZFTA fusion. In the posterior fossa ependymoma, you have a broad classification of PFA and PFPs, and anything that has any kind of overlapping features or unclassified has its own separate classification of posterior fossa ependymoma. In the spinal cord, it's been refined a little bit more with the understanding that some of the MICN amplified classic ependymomas tend to have a little worse prognosis, and they have been separated. From the ones that are not MICN amplified. And finally, you have the age-old two other tumors, which is the myxopapillary ependymoma, which is seen in older children and adults, and subependymoma, which is predominantly seen in adults. And so this is the newest classification, and we are already seeing most of the institution integrating this classification into their diagnosis. So it's a welcome change. The clinical features, as we all know, mirrors the location of the tumor. In the posterior fossa, they often present with obstructive hydrocephalus, resulting in raised ICP and the classic features of raised, present with ataxia and lower cranial nerve deficits and motor weakness. In the supratentorial area, depending upon the location, seizures can be a predominant feature, accompanied by headaches and vomiting, and focal neurological deficits if it is causing any obstruction to the components of the internal capsule or the white matter. The ependymomas among high-grade gliomas are kind of unique in the sense they are different from the embryonal tumors. These are glial tumors, and hence their potential for metastasis is not as much as in the embryonal tumors. They're often localized to the compartment of origin, and metastasis is rare at presentation. However, you have about 5 to 10% of the patients who have either CSF positivity or a macroscopic seeding as reported in the literature. And hence a complete workup, including an MRI of the brain and spine, is mandated in these patients. And whenever possible, a lumbar puncture is encouraged. However, there are situations that lumbar puncture may be contraindicated in these patients, and hence you may proceed with a treatment based on just an MRI of the brain and spine, given the very low incidence of CSF positivity in these patients. Also, it is still a matter of debate as to how you will treat patients who have otherwise localized disease but a CSF positivity. There are at least case reports and our own experience where some of these patients may still be treated with radiation, focal radiation treatment, and they may be cured. And so while every attempt has to be made to do a lumbar puncture in these patients, if there is a rare patient that you may have to skip the lumbar puncture because of medical reasons, that seems to be acceptable in these patients. How about the histology? Why did the WHO do away with the histological grading into classic and anaplastic ependymoma? And the reason for that is there have been several studies looking at the grading of the ependymomas and their relevance. And when you look at this, when you do a meta-analysis of these studies, there is a wide spectrum. There is a wide range, and the ratio of studies which have looked at grade 2:3 ranges anywhere from 17:1 to 1:7, which means there are some studies, which will give you a predominance of grade 2 histology, with other studies which give you a predominance of grade 3 histology. As any pathologist can tell you, it is extremely hard sometimes and can be very subjective to differentiate a classic and anaplastic ependymoma. Also, when you look at the association between the outcomes between histological grading and outcomes, you will see that there are studies of ependymoma that show no association between outcomes, which outnumber that show an association between outcomes. And I will, and I can give you at least 2 examples here. One primarily the COG study, ACNS I think it was 0121, which was published recently by Dr. Tom Merchant, which showed that there is a difference in outcomes when you look at the histology, whereas some of the St. Jude studies, which I'll present, did not show a difference. And so given the subjectivity, it was always a matter of debate as to whether the histological grading really matters in these patients. And finally, I'm going to quote this study, which is by David Ellison, who's one of the pathologists who works at St. Jude and also is the co-author of the WHO CNS5. Then this was a study which was undertaken when David was in UK, when he was working in UK, where based on 5 European trials, there was an attempt to see a consensus classification of these tumors and correlate to outcome, where 5 neuropathologists sat down and looked at the data from 3 different PSYOP trials and evaluated the grading and other pathological variables and looked at the outcomes. And as you will see in this bar diagram here, you see the wide variation among each of the pathologists in calling each of these tumors as grade 2 or grade 3. And these are very well trained neuropathologists. And so when the neuropathologists with experience are having so much of difficulty in calling these tumors as grade 2 or grade 3, you can only imagine how some of the less experienced pathologists may have trouble. And hence, it was determined to get away from this histological classification and call them as straightforward ependymoma, and then try to integrate the molecular features, which are now found to be more relevant than the histological features. So finally, the consensus from this study was that there was no robust association between grade and outcome. That was published quite some time back. And so these are the background into which the WHO considered before moving on to a classification where we no longer use grading system. How about the molecular classification? How has the molecular classification changed the practice, and what does the future look like? Now, as we know, the molecular classification of central nervous system tumors are primarily based on gene expression profiling or by DNA methylation profiling. And so it is thought that these molecular classification better reflect the oncogenic mechanisms and also the specific cell types during tumors histogenesis. And more importantly, from a clinician's perspective, they can be associated with clinical, various pathological, genetic, and biological variables, and also can predict outcomes. And so most of the brain tumor classifications are now moving towards an integration of the molecular features, and also sometimes to even confirm diagnosis where there is some discordance or difficulty in making a histological diagnosis. So here we are. This is the classic figure, which probably gets referenced in most of the conferences. Since this was from the original Cancer Cell paper, as you know, there are 9 molecular groups that is related principally to the anatomic side. The simplest way of remembering this is there are 3 in each of the compartments, 3 in the supratentorial area, 3 in the posterior fossa, and 3 in the spinal cord, as is depicted in this figure. However, what is important from a pediatric perspective, that even though 9 molecular groups have been identified, there are 4 groups that we have to be familiar with. And those are, in the posterior fossa area, you have the PFA and the PFB group of tumors. That's depicted here down in the figure here at the bottom of the figure. And then you have in the supratentorial area, you have the supratentorial ependymoma relay fused, which has now been changed. The terminology has been changed to the ZFTA, and I'll come to that in a short while. And then you have the supratentorial ependymoma YAP fused. Why is it important that we know this molecular classification? Is because this figure on the right, as you will see, these are the 4 classifications here: the supratentorial relay, YAP, PFA, and PFB. And as you will see in this figure here, these tumors have a distinct age of presentation. This is the distribution of age in the 3rd column here, in the 4th column rather. And then you have the outcomes in the last column. And as you will see, that PFB group of tumors and the supratentorial YAP group of tumors have excellent outcomes, to the point that there is even discussion among the neuro-oncology community that if we should even treat them at the first diagnosis. But again, this is something that needs to be confirmed. And whereas the PFA group of tumors and the supratentorial relay group of tumors generally tend to have inferior prognosis. And so that's the main relevance for us as neuro-oncologists or radiation oncologists treating patients with ependymoma. By molecular mechanisms, it has also been shown that the oncogenesis and the molecular pathways are completely different for all of these tumors. And hopefully in the future, we'll have more targeted or treatments that are directed specifically to each of the molecular groups once we have deciphered this code completely. So that's the relevance as of now for us. What about individual groups? And as I mentioned, now PFA group of tumors in the posterior fossa, you have two main group of tumors, which is the PFA and PFBs. And there is a marked difference in survival on these patients. As you will see, the PFB group of patients have certainly better outcomes as compared to the group A patients. More importantly, there are a certain subgroups of PFA patients, especially the ones with 1Q gain, which have even inferior outcomes as compared to the rest of the population. And coming to the biological relevance and how is there a way for us to histologically make this diagnosis, as we know that DNA methylation techniques are not easily available sometimes, even in Western countries where there are a lot more resources. So is there a more simpler way of diagnosing PFA and PFBs? And the answer is yes. And that is based on this study, which came out of from the Michigan group. Dr. Sriram Veniti, who's actually incidentally from Bangalore, he works at the University of Michigan and led the team which showed this outcomes that we showed this finding that the PFA group of tumors have a dramatic reduction in the histone trimethylation. Now, this is similar to the midline high-grade gliomas, although the pathogenesis in ependymoma is completely different, which again, I'll come to it a little later. And this is something which can be detected by immunohistochemistry. And as you will see in the figure here, in PFA group of tumors, there's a 100% loss every single time there's a nuclear loss of histone trimethylation, which can be detected by immunohistochemistry. So you don't need advanced techniques like DNA methylation in your patient to determine if it's a PFA or PFB. Another thing that the practicing clinicians have to keep in mind is the PFB group of tumors is predominantly seen in older children. The youngest age reported with PFB group of tumors is 5 years. And so in infants and toddlers, where there is a high incidence of ependymoma, you can practically consider that in the posterior fossa, if there is a tumor, it's probably going to be a PFA group of tumors. But regardless, the pathologist can actually give you that diagnosis based on immunohistochemistry. Now, what about the pathogenesis? How does this happen? How is that ependymoma cells, there is a nuclear loss of histone trimethylation, which is similar to diffuse high-grade glioma. But there, in diffuse high-grade glioma, this loss is because of histone mutations. Now, histone mutations are not common in ependymoma. It's reported in less than 3% of the patients. Instead, there is an alteration of a gene called as CXOF67, which binds to PRC2 complex, which is part of the chromatin regulating complex. And through that, there is a downregulation of the histone trimethylation and eventually a loss of histone trimethylation, which is then picked up on the immunohistochemistry. This is because CXOF67 mimics the action of the H3K27M, which is the altered histone mutation that you see, altered histone protein that you see in diffuse midline gliomas. And because of the similarity, they function to have the same end result, which is a loss of histone trimethylation. And this gene has now been renamed as EZIP, which is the EZH2 inhibitory protein. And so this is the pathogenesis, slightly distinct from diffuse midline high-grade gliomas, but histologically, this is a finding that can make it easy for you to make a diagnosis, although your treatment paradigm will not change depending upon whether it's PFA or PFB, but at least it will give you an idea as to what you're dealing with. Now, what about the supratentorial areas? Now, the supratentorial ependymoma the classification has evolved a little bit as with the understanding that previously what we called as the C-OFF1195 relay fusion, and the relay is the one which drives oncogenesis. Now the thinking is that no, probably it's the C11OFF95 which drives the oncogenesis, because there are a substantial number of pediatric supratentorial ependymoma patients who do not harbor this fusion. They have non-relay fusions, and hence this terminology has changed. However, I'm quoting this survival curve from the original Cancer Cell paper by Christian Patlar, where it clearly demonstrated an improved outcome for children with the YAP fused of ependymomas, almost 100% survival, as compared to those with the relay group of tumors. Now, this outcome has also been questioned as more data is coming from prospective studies. We are now understanding that not all supratentorial relay group of tumors have bad prognosis. There are certain other molecular features like the homozygous deletion of CDKN2A that accompanies some of these patients that actually determines the worst outcomes rather than the Raleigh group of tumors. So again, it is a field that is evolving rapidly. However, and unfortunately for us clinicians, the treatment is not keeping up pace with the molecular advances. So why was the change of terminology? Why did Raleigh-fused ependymoma be reclassified as the supratentorial ZFTA-fused ependymoma? And the couple of reasons for that is that, as I mentioned, previously what we thought of as a consistent fusion in supratentorial Raleigh tumors, the C11orf95 and the Raleigh gene, is not sometimes seen in some of these tumors. Instead, the C11orf95 fuses with some other partners. Okay? So clearly telling us that it's not the Raleigh which is driving the oncogenesis, but it's probably the C11orf95. Now, there are also histologically ependymoma patients that are by DNA methylation are not being assigned to the Raleigh group of tumors. And so there was some discrepancy between histology and DNA methylation. And as this one of the papers that have, this is from the Japanese group, they found that there are other partners that are driving oncogenesis in these patients. And so there are 3 studies that came out simultaneously earlier this year. And it was a multi-institutional international collaborative group of study, which was all published in the same journal, which looked at C11orf95 as the culprit instead of blaming Raleigh for the oncogenesis. And they have shown in various basic science experiments very beautifully that it is the C11orf95 which is driving the oncogenesis, and renamed this gene as ZFTA, which is, I believe, zinc finger associated transcription activator. So it is going to be called the C11orf95 is going to be called from here on as the ZFTA gene, and the supratentorial Raleigh tumors are now going to be called as supratentorial ZFTA fused tumors. So that's been the big change that has happened this year, and that has been shown in 3 different studies. And so that's the change in terminology which has happened recently that we are seeing in the WHO CNS5 classification. What about the treatment? Has the treatment changed over the years? And the answer is yes. I think there has been a little bit of change in the treatment. More recently, in the last couple of years, there is more discussion about the role of chemotherapy. There is more discussion about just observation following surgery rather than radiation. And so I'm going to review some of the treatment aspects here, and then we can build upon that using some case vignettes. So as most of us know, until very recently, prospective studies which have used immediate post-operative focal RT have demonstrated the best outcomes to date. And this was shown very beautifully in a study by Dr. Tom Merchant from St. Jude, which was published in 2009, where he used, for all non-metastatic patients, immediate post-operative focal RT with a 7-year event-free survival close to 70%, as compared to the chemotherapy alone approach, which was used by the UK group and was published earlier. And as you will see here, the 5-year event-free survival for non-metastatic patients is about 47%, and the 5-year RT-free survival was only 42%. The curve in red represents non-metastatic patients, and the curve in blue represents metastatic patients who clearly have no chance with chemotherapy alone. You will have to use radiation. However, an important point to note is that ependymoma is a very indolent tumor. Any report that quotes just 5-year survival is just not adequate. You need to follow them a little longer. And as you see here, when you follow these patients a little longer, in the curve on the right, you'll see that by 10 years from diagnosis, you have only about 30% of the patients who are cured with chemotherapy alone. Now, it is an important factor to keep in mind that there are some patients who can be cured by chemotherapy alone, but the outcomes are far superior with the use of focal radiation. And hence, radiation therapy following surgery has been the standard of care for quite a while now, and continues to be so for a majority of the patients. Okay. So safe maximal resection, the neurosurgeon obviously is going to be your best friend in these patients. The more they can get out, the better. And several studies have shown time and again that the extent of resection is prognostic in these patients. And anyone with a gross total resection or a near total resection have far superior outcomes as compared to those patients with a subtotal resection or a biopsy only. Historically, the researchers have also observed that a supratentorial location is better than a posterior fossa location. Now, this may be partly because a gross total resection is probably easier to achieve in a supratentorial area rather than in a sticky brain stem location. Or it also could be explained by the molecular factors that you have the YAP-fused tumors, you have the less benign, the less aggressive Rayleigh tumors, which have better outcomes. So you'll never know because there is no molecular data available from these from these historical studies. Now, this is the minimum age for administering radiation. It's always been a matter of debate, right? What is the minimum age? When do you feel comfortable using radiation therapy? Even in a posterior fossa tumor, these patients can have adverse outcomes many years down the line. And it has been a matter of debate. For most institutions, and I'll come to it in a while, 1 year of age is when people would be comfortable using radiation. Anything less than that, probably people are not comfortable and they would probably use chemotherapy as a bridge. But regardless, one of the most important things is, as of today, despite the molecular advances, the treatment recommendations have not been based on molecular groups, but this is something that will happen in the future. What about the role of chemotherapy? Where do neuro-oncologists fit into the treatment of ependymoma? Is this a disease primarily to be treated by a neurosurgeon and a radiation oncologist? Now, there are specific indications for chemotherapy for patients with ependymoma. And the standard chemotherapy drugs, like any other brain tumors, which has been found to be effective and been studied in several studies, are the platinum group of drugs, cyclophosphamide, etoposide, and vincristine. These are the more effective drugs. However, most studies will at best document a partial response. A complete response with these chemotherapy agents in patients with ependymoma is still very rare. Importantly, there are no randomized trials comparing immediate radiation versus chemotherapy alone following surgery. Whatever data we are quoting, it's from separate trials which have shown radiation to be more effective than chemotherapy. Different cooperative groups across the globe have tried using only adjuvant chemotherapy and delayed radiation. And most of these studies demonstrate a 5-year event-free survival anywhere between the 20 to 42%. However, as I told you, you may avoid radiation at 5 years, but that necessarily does not tell you what is the actual outcome is. You need to follow them a little longer. And regardless, most of these patients will end up getting radiation treatment. How about the chemotherapy in young children? What do you do if you have a 4-month-old with a brain tumor with ependymoma? And one of the results that most institutions probably use the baby POG, the baby POG chemotherapy combination agents for 6 months or 8 months or a year or 18 months. Most of the institutions are comfortable doing that. One of the things that we published a couple of years ago from St. Jude was a St. Jude infant brain tumor trial, the STA-YC07, which was primarily for children less than 3 years of age of different brain tumor diagnosis, including ependymomas. This was a multi-institutional trial with 7 institutions. The inclusion criteria was newly diagnosed ependymoma patients less than 3 years of age. Those with metastatic disease were classified as high risk, and those with non-metastatic disease as intermediate risk. The main goal of this study was to defer radiation in the very young children till at least 1 year of age and see if chemotherapy improves outcomes in this patient. So the 2 main objectives. This is the chemotherapy regimen. As I said, it's already published in Neuro-Oncology Journal. But just to summarize, all patients received 4 cycles of induction chemotherapy using IV methotrexate of 5 grams per meter square and the conventional chemotherapy agents of vincristine, cisplatin, and cyclophosphamide, as is described in this table. Now, following 4 cycles of induction chemotherapy, all patients were to be considered for repeat resection if they had any residual disease in an attempt to achieve gross total resection prior to focal radiation therapy. Now, for the metastatic disease patients, they did not receive any radiation, but they were supposed to receive induction chemotherapy and consolidation chemotherapy using cyclophosphamide and topotecan. It's again delineated here. All this chemotherapy regimen is delineated here and published in Neuro-Oncology Journal. And what we saw was that among the 54 patients, 53 patients had non-metastatic disease, M0. No evidence of metastatic disease, both by imaging and CSF analysis. There was only 1 patient whose CSF showed tumor cells. However, that family opted against chemotherapy. They did do the induction chemotherapy and then proceeded with focal radiation. And about 5 years after the diagnosis, the patient is still doing fine without any relapse. And hence, I think it's very important if you get a positive CSF in ependymoma patients, confirmation by repeating a lumbar puncture after a certain number of days, maybe even up to a week or 2 weeks is necessary, because it's not such a rare occurrence, and hence, you could avoid CSI in these patients. Now, what are the main findings of this study? We did molecular analysis on this study, and as you will see here, majority of the patients belong to PFA group. We had 12 patients in the supratentorial compartment, 8 of them belonging to the relay, and 4 belonging to the YAP. This is the histological classification. Majority of them had anaplastic histology. Majority of them at the end of induction therapy following second resection had either a gross total resection or near total resection, with almost 90% of the patients having either achieved a GTR or NTR prior to proceeding with radiation. Another important finding, the 1Q, the presence of 1Q in PFA group of tumors. Now, 1Q is a molecular finding, the somatic or the tumor 1Q is a molecular finding which has been associated with adverse prognostic factor. Fortunately, the incidence is very low. In our cohort, it was about 12%. So only 12% of the patient had, 12% of the PFA patients had 1Q gain. Now, this 1Q gain is not of relevance in any other molecular groups. So really not an important finding that you need to go after in the other group of tumors. What about the outcomes? The 4-year outcomes, and we reported only 4-year outcomes because the median follow-up by the time of publishing this study was about 4.5 years. The 4-year outcomes look excellent, 75%. But as I mentioned, please see what happens by the time they get to 10 years of follow-up, almost 50% of the patients relapse. And hence a long-term follow-up of at least 7 to 10 years is required in these patients before you can call them really cured from this disease. Okay. The other outcomes, we looked at outcomes by molecular groups. And what we saw was the patients with the PFA group of tumors had the worst outcomes. And as against what was reported in the literature, patients with relay group of tumors actually did not do very poorly. The numbers are small, you have to keep that in mind. But when you look at those numbers, really, even at 5 years, 10 years from diagnosis, almost 80% of the patients actually did well. Now, this was in contrast to the retrospective studies, which had shown that relay group of tumors do very poorly. So that doesn't seem to be the finding anymore. There are other molecular features like CDKN2A deletion that you have to consider. In the presence of CDKN2A deletion, there has been one study which has been published by the German group, which has shown that they could have inferior outcomes. This is the outcomes with respect to the PFA and 1Q gain. As you will see, the curve in black represents PFA with 1Q gain, and almost all of them have failed treatment so far except one patient. So it's a high-risk molecular feature where you have a high incidence of treatment failure. Very interestingly, though, there are 2 groups of patients with PFA and 1Q gain. Some of them relapse within a short period of time, within 2 years, which is majority of the case. And then you have a smaller group of patients who relapse after 5 or 6 years. I just had a patient 3 months ago who relapsed, unfortunately, after 4.5 years from diagnosis, and he had a PFA with 1Q gain. So again, something that you need to follow up. And another important thing, interesting finding we found from these studies was that even though they may not have 1Q gain at diagnosis, at relapse, some of these patients are positive of 1Q gain. It seems like there is a clonal evolution of treatment-resistant clones bearing 1Q, which will relapse after a while. So something interesting to be looked at in your patients, because it can be easily detected by FISH technique. You don't need any fancy techniques. What about the extent of resection? As I mentioned, the extent of resection is still very prognostic. The neurosurgery team is still going to be your, you have to be friends with the neurosurgery team. And here, as you see, children with subtotal resection had inferior outcomes with a 4-year survival of only 40%. We did not detect any difference in outcomes by histology, again emphasizing the fact that despite our study having a large number of anaplastic histology patients, their outcomes did not seem to be inferior as compared to those with grade 2. Again, emphasizing that maybe histological grading is not that important. And finally, very importantly, outcomes by age. I'm sorry if this curve is not projecting very well, but basically what this curve is showing is the darker curve is children with more than 1 year of age at diagnosis, and the lighter one is children less than 1 year of age at diagnosis, clearly showing that when you use chemotherapy as a bridge, get them to 1 year of age, then use focal radiation therapy, they can still have very good outcomes as compared to children more than 1 year of age. So age in itself is not an adverse prognostic factor for most of these children. What about ACNS 0831? And I kind of alluded to this in the SIOP talk as well. This was a data which has just come out in the last 6 months or so. Dr. Amy Smith has presented, who was the principal investigator of the study, presented it in ISPNO last year. And just briefly, again, this is a very busy slide. I'm sorry if it's not projecting very clearly, but basically the gist of this was that all patients with newly diagnosed non-metastatic ependymoma underwent surgery upfront, and they were enrolled on the study after a central review of pathology. Now, at the time of enrollment, if these patients had either a gross total resection or a near total resection, they underwent randomization to either radiation alone, okay, all of them got radiation, to radiation followed by observation, or radiation plus 4 cycles of maintenance chemotherapy. And this maintenance chemotherapy included vincristine, etoposide, cyclophosphamide, and cycle 4, vincristine was skipped, and cyclophosphamide and cisplatin. And in cycle 4, vincristine was skipped, and I'll come to that in a while. Now, for the patients who had subtotal resection, that's a randomization. For patients with subtotal resection, all patients were to receive 2 cycles of induction chemotherapy. And why is this? Because the attempt was to give chemotherapy to maybe reduce the size of the tumor, to reduce the vascularity, and consider them for a repeat resection. It was necessary to consider them for a repeat resection with an attempt at gross total resection, because we knew historically that extent of resection is prognostic. So is it possible that by giving chemotherapy, we can help with the repeat resection and improve outcomes? So that was another objective of this study. Now, these patients who had an initial subtotal resection, they also underwent radiation, but they were not randomized. All of them were mandated to receive 4 cycles of maintenance chemotherapy, assuming these are high-risk patients. So this was kind of the overall gist of the treatment plan in this study. But the main question was whether adjuvant chemotherapy following radiation therapy would benefit these patients and improve outcomes. So that was the main objective. Here is the chemotherapy that was used post-radiation treatment. This is a standard chemotherapy regimen using vincristine, etoposide, cisplatin, and cyclophosphamide, which has already been published and already been presented. In cycle 4, vincristine was skipped because of the risk of neurotoxicity. Be very mindful here. The dose of cisplatin is 100 milligram per meter square in children more than 0.45 meter square body surface area. And this induces a lot of ototoxicity. And a lot of these patients do end up with hearing loss. So hearing is very strictly monitored after every cycle. And majority of the patients will unfortunately require a dose reduction, something to be closely followed. Myeloid growth factor was provided till the ANC was more than 1500. So each of these cycle was a 21-day cycle, and 4 such cycles were administered, with vincristine being skipped in the last cycle. What were the outcomes? So these are the outcomes that as of now have been presented. Please remember, the molecular analysis is not completed. So some of the treatment recommendations may change when the complete analysis is done. This study had a total of about 470 patients. The randomization was almost equal. RT alone was 161 and RT plus chemo was 164. Based on the intent to treat analysis, the 3-year event-free survival for patients with radiation alone was 72%, and for patients with RT plus chemo was 78%. Now, this did not reach statistical significance, but it was still significant because what happened was, even though intent to treat analysis is considered the best statistical paradigm, unfortunate thing was there were a lot of patients who refused chemotherapy following radiation. So there was a lot of dropout rate. So based on as treated analysis, so as you see, 30% non-compliance rate in the RT plus chemo. So based on the as treated analysis, based on how many patients got radiation alone and radiation plus chemotherapy, when the outcomes were looked at, the children with radiation alone, treated with radiation alone, had a 3-year event-free survival of 71%, and those with radiation plus chemo had an event-free survival of 80%. So approximately 10% improvement in survival. And of course, this was statistically significant. However, the most important finding was that this benefit seemed to be, this benefited only those patients who had an initial gross total or a near total resection after initial surgery. So despite everything, the pressure on the neurosurgeon still remains to provide us with patients who have a gross total and a near total resection. However, the important thing to remember is if you're not able to achieve a gross total resection at the initial setting, you can always give a couple of rounds of chemotherapy, try to shrink this tumor, try to reduce the vascularity, and then the neurosurgeon can do an attempt at resection. So here are the recommendations from the ACNS 0831 study. Patients with non-metastatic ependymoma and a gross total resection after the initial surgery benefit from post-RT maintenance chemotherapy, and as such is recommended for this group of patients. Patients with an initial subtotal resection do not benefit from post-RT maintenance chemotherapy. Now, patients who have had non-metastatic ependymoma and who failed to undergo an initial gross total resection, regardless of their subsequent resection status, okay? You had a subtotally resected patient, you gave 2 cycles of chemotherapy, you achieved gross total resection, you gave focal radiation. Now, this group of patients do not seem to benefit from maintenance chemotherapy, so do not administer chemotherapy to them, okay? Now, most importantly, preliminary results, these are very preliminary results. They have to be followed by molecular analysis to determine specifically which group of patients will benefit from adjuvant chemotherapy. I also want to emphasize, although we are following these guidelines at St. Jude, there are some institutions who are still not following this or are waiting to see more data from the complete analysis. So still, there is question about what is standard of care. I think it's very important that as treating physicians, you have a very discussion with the families. And in my own experience, there are some families who have refused post-radiation chemotherapy despite these analysis. And so I think till there is more data that comes, we'll still be wondering whether chemotherapy is beneficial for these patients. But one of the things to remember as treating neuro-oncologists, as we all know, recurrent ependymomas really have not much of curative options. So your first chance is always your best chance. So I think optimizing care and giving chemotherapy is pretty reasonable in these patients. So what are the conclusions? How do we treat non-metastatic ependymoma patients? Whenever feasible, attempt a gross total resection followed by focal radiation. Otherwise, proceed with safe maximal resection. And in these patients, there is an indication for chemotherapy. Also an indication for chemotherapy is infants less than 1 year of age. Follow safe maximal resection to bridge them to radiation till 1 year of age, or at whatever age you're comfortable radiating. Now, the second group of patients where chemotherapy is indicated, if there is a less than near total resection at diagnosis, administer chemotherapy. Request your neurosurgery team to consider a second resection aimed at gross total resection. Finally, the most important recommendation, which has come out of ACNS 0831, any child with an initial gross total resection followed by radiation therapy must receive adjuvant 4 cycles of chemotherapy. So that's the most recent recommendation. I'm going to end with 3 case vignettes, just highlighting the things that we talked about. We have a 5-year-old boy who presented with headache, double vision, somnolence, papilledema, the usual symptoms. As you will see, the MRI here, T2 flare images, is showing a large centrally cystic and necrotic tumor and a nodular and a peripheral nodule. This patient underwent an initial subtotal resection. The histology was consistent with an anaplastic ependymoma, relay fused. Staging workup was negative. The patient was enrolled on the ongoing trial at that time, received 2 cycles of induction chemotherapy. Our surgeons were able to go in and operate on him again and this time achieved a near total resection. We consolidated him with radiation therapy. The family refused maintenance chemotherapy, so we stopped at radiation and kept him under close observation. Unfortunately, 3.5 years later, he has now had a local recurrence. And this patient did have a CDKN2A deletion in his tumor, so clearly a high risk negative prognostic factor. Okay, so first instance, if you have not achieved a gross total resection initially, attempt a couple of rounds of chemotherapy and then attempt a repeat resection and then proceed with radiation treatment. Second instance, an infant, a 4-month-old girl who came with nystagmus and macrocephaly. As you will see, a huge tumor in the left parieto, pretty much the whole of left side of the brain. Initially underwent a subtotal resection, then was referred to our institution. The neurosurgeons went in and operated and were able to achieve a gross total resection. Histology was consistent with a grade 3 anaplastic ependymoma. Staging workup was negative. Now, since she was only 4 months of age, we bridged her with a few cycles of chemotherapy. And then when she got to 14 months of age, we administered radiation. She's about 6 years from diagnosis now, doing well. And so a second instance where chemotherapy can be used as a bridge in the very young infants to get them to 1 year of age or 18 months of age, at whatever age you feel comfortable using focal radiation treatment. Now, the problem is if you wait too long, these tumors can come back, and then you have lost an opportunity. You may have to go in and resect these tumors again. So the timing of radiation is very important in these patients. And finally, my last patient, 4-year-old boy with ataxia, headache, and vomiting, presented with the posterior fossa mass, underwent a gross total resection. Histology was again a grade 3 anaplastic ependymoma, and he had gain of 1Q in the tumor detected by FISH. Staging workup was negative. He was enrolled on the COG trial, received radiation followed by chemotherapy. Unfortunately, about 4 years later, relapsed locally, and then we used re-radiation in him. And 2 years later, he's doing fine, but he makes me nervous every time he has a scan. I'm always nervous, and so does the family, because we know he's high risk for treatment failure. So now these are the instances where you would use chemotherapy. These are also the instances which are highlighting the standard of care for newly diagnosed patients. Pretty reasonable, I think, and can be applied in any setting. My last slide, in fact, my last but one slide. So this is the up-to-date material that I'm going to share, which is why I shared the conflict of interest disclosure. And this, in its management, in the very end, we have outlined the algorithm for management of newly diagnosed ependymoma patients. I'll let you read through it in the up-to-date site, but this is a treatment algorithm that is there on the site. And finally, one slide on recurrent ependymoma. What options do we have for patients with relapsed recurrent ependymoma? And unfortunately, about 50% of the patients will have relapse at some time. One of the treatment modalities which has been published by several people is re-radiation. I'm just going to highlight one of the studies, again by Dr. Tom Merchant, which showed with re-radiation, a 5-year overall survival of 57% from the time of relapse. This is from the time of relapse, and the freedom from progression of about 35%. So there are a certain number of patients who can be cured by re-radiation. So something that you have to keep in mind. The problem is knowing whether to do focal radiation or CSI. And this is one graph which I'll try to dissect it out. Now these are 1, 2, 3, 4 are basically referring to local failure that was treated with focal RT at relapse, distant failure that was treated by CSI, combined failure treated with CSI, and then local failure treated with CSI. And as you will see from the curves here, the best outcomes are seen in patients who had distant failure but received CSI, followed by patients who had local failure with focal RT. And so whenever there is a distant failure, obviously, it makes sense to do CSI. So those are the patients that seem to have the best outcomes in these patients. The ones that have the worst prognosis is patients who have a combined failure, and even with CSI, their chance of survival is only about 10%. So consider this for some of your patients. One of the other things which is important is the time to recurrence. Any patient who recurs more than 4 years from diagnosis had the best chance of survival. As you will see, about 60% chance of freedom from progression with re-radiation. And anyone who relapses early, less than 2 years, obviously has inferior outcomes. Finally, chemotherapy. There were some studies who have been published on chemotherapy, and I'm going to highlight 2 of them for anyone who have exhausted all other options. Now, this was a study which came out recently from the German group. Nothing too exciting. As you see, the column on the right here, medium time to progression, pretty much everyone progressed pretty quickly. But there was an interesting, outstanding feature. There were some patients who received sirolimus who had a median time to progression of about a year. Again, the authors don't seem to have a good explanation for it, but these are various chemotherapy regimens that is used. I'll refer you to that paper which was published in Journal of Neuro-Oncology if anyone is interested. And finally, conventional chemotherapy. This was a paper that was published out of St. Jude way back in 2009. It's a carboplatin-based chemotherapy regimen for relapsed brain tumor patients. And one of the findings was that among the 9 M0 ependymoma patients who had relapse and who underwent a gross total resection, they had a 5-year kind of event-free survival of about 50%. So there seems to be some patients who, despite everything, despite chemo resistance, do benefit from chemotherapy. So can be considered for patients where you have exhausted treatment options that may proceed with gross total resection, ask the neurosurgeon to operate on these patients. And if it's a non-metastatic disease, gross totally resected, you have a treatment option. Again, it's a very simple carboplatin-based chemotherapy option. But as you see, patients do suffer. There is a lack of treatment option for these patients. It's a really difficult disease to cure in a significant number of children. while molecular advances are telling which are the high-risk groups, unfortunately, that's all we can share with the families. We are like, sorry, we don't have any other treatment. You're still high risk for treatment failure. Radiation is still the best treatment modality. There are specific indications for chemotherapy, as I mentioned, infants and those who have undergone gross total resection. However, and hopefully in the future, clinical trials which will target some of the biological mechanisms will improve outcomes for these patients. But unfortunately, this is a very stubborn disease, especially for the ones who fail after frontline therapy. I will stop here and see if you have any questions.
Thank you, Santhosh, for a wonderful, exhaustive presentation on ependymoma. So over to the chairpersons for further questions.
Thank you, Dr. Santhosh, for that exhaustive overview of ependymomas in children. It has thrown open many new way of looking at ependymoma, recurrent ependymoma, and how do we tackle this very stubborn disease, as you have said. The most important thing is the first treatment. And the problems that we generally face is that if the first surgery is done not by optimally, and we immediately, like we generally face the patient population where there is a suboptimal surgery, and you may feel that you can do the resurgery at the outset, but then the acceptance of such is very, very difficult. So such patients, can you take up immediately? Like you have got a tissue, so it is as good as a biopsy, which you can process for a detailed molecular workup and all that from a good center. And then you take it up rather than doing resurgery at the beginning. You give the chemotherapy, and then having built the rapport and having a faith in the system, they may agree for the resurgery. How do you overcome this problem? Because this is a very common clinical scenario that we face.
Yeah, no, I completely agree with you, madam. And I think this is a problem that that exists where we practice also. There are some families who have just come out of surgery, and many of them have, they end up with tracheostomy, G-tube, and sometimes with posterior fossa syndrome. They're extremely reluctant to go in for a second resection. I think, to be honest, we are at a little bit of an advantage being at St. Jude because of the reputation of the institution and the surgeons. So most often they do listen to us. But again, we run into that problem also. And I think you answered the question very well yourself, that could we use chemotherapy as a bridge, gain the trust, and then consider a repeat resection. And I think that's what we do in most of the instances also. Unless the family is in complete agreement, unless the neurosurgery team is in complete agreement that this is operable, this is completely resectable, we generally use chemotherapy as a bridge, and not only to help with the healing of all the complications from the first surgery, but again, as you said, to gain the trust. And also, I think, the neurosurgeons themselves have come back and told us time and again that when we have used chemotherapy, that it has made it easier for them to operate. Even if the tumor has not shrunk very much, it reduces the vascularity around that tumor and makes it easier for them to operate. So I think it's probably the best thing to do instead of rushing, especially understanding that ependymomas are indolent tumors and they're not going to grow overnight. So using a chemotherapy approach of 6 to 8 weeks and then send them for repeat resection, I think that's probably what we would do as well. And I think the availability of neurosurgical expertise is obviously an important consideration here, isn't it? And there is a lot of push, even in the United States, that if there are small centers which have not operated on children, if it's an adult neurosurgeon who has not had much experience with pediatric brain tumors, just stabilize this patient, send a biopsy or something, and transfer them to a bigger center. So I think availability of chemotherapy option and availability of neurosurgical expertise is ultimately what will help us as neuro-oncologists. So.
Thank you.
Yeah. So, Dr. Santhosh, Tejpal this side. Although I'm not a surgeon, I'm a radiation oncologist, but I think most of the time, the surgeons are even more reluctant than the families to go in again.
Yeah.
And I mean, posterior fossa ependymomas particularly, I mean, the kinds that we see sort of insinuating into the foramen, very difficult to get a gross total resection. They're not very vascular tumors. So I'm not so sure how the surgery would become relatively easy following chemotherapy. I mean, unlike a say a choroid plexus carcinoma or a choroid plexus tumor, which is very vascular, and with the chemotherapy, you really reduce the vascularity and reduces the blood loss. So most of the time, it's the surgeons rather than the family. Of course, the family is also reluctant, but I think the surgeons are more reluctant than the family to go in immediately, and even after giving chemotherapy. We really don't practice too much of chemotherapy followed by second look surgery. I think our surgeons normally would do a maximal safe resection, and if that means achieving an NTR or a GTR, we would try to do that, but not be overly aggressive and precipitate deficits. So I think, but even our neurosurgeons would be very reluctant to go in again if they feel that something has been left behind by them. They would really not want to go in again because they have left it behind because of certain reasons.
Yeah, and I completely agree. I think, you know, when our neurosurgeon, that's why I said in the beginning that unless the family and the neurosurgeons are in complete agreement, I think many a time the neurosurgeons themselves have come back and said, listen, it's on the brainstem, it's too sticky, and I'm going to give a trach and a G-tube for this child if I go in and operate. We have just let it go. We have to work with what is available. And I think we have been in a situation also where we have managed with just a subtotal resection, with the understanding, obviously, these are very high-risk patients for relapse, especially the ones with 1Q gain. So it is a practical problem. I completely agree with you. It's a practical problem. However, I think, you know, it's also the one that gives the child the best chance at cure. So ultimately, I think it's a very sensitive issue that depends upon a lot of things, including family acceptance and neurosurgical expertise. Yeah. Unfortunately, as you said, these are very sticky posterior fossa tumors and not easy to operate on. I mean, I could sit here and give, say 1,000 things. I'm sure the neurosurgeons will be, you know, yelling at me like, you know, what are you talking about? It's not such an easy thing. And I understand that.
Yeah. So just also, I wanted to ask you, if you have a PFA with the 1Q gain, is there any merit in considering, and this question has been asked to me several times, I always say no CSI, but increasingly many people ask that question. I mean, you know that they're going to fail distally. Why can't you just do the CSI and try and reduce that risk? And we do the CSI when they fail. I mean, even locally. Right. And if there is a 1Q gain, we do the CSI.
I think the important thing is most of them do fail locally. They do a good number of patients will fail metastatically, but still the majority of failure is still local, right? And considering that these are such young infants, understanding that even CSI may not be curative in these patients, it's questionable. And it's just a very hard sell for me to do CSI in a 1Q gain patients. Yeah.
No, even when they fail locally, I think St. Jude's also does CSI if it is 1Q gain is present, even if it is only a local failure.
No, so there is in the re-radiation protocol of Dr. Tom Merchant, which closed just now, I think a few months ago, there was an option for patients with 1Q gain when they fail at the time of failure for consideration of CSI. And I think we are still awaiting the results of that trial to see if CSI was even beneficial. I think the problem, sir, is like we don't have data to support that CSI is actually going to be beneficial, right? So we'll have to see what Tom Merchant's data is going to throw up. But even there, I think majority of the patients, he ended up doing focal re-radiation. But there was, I think, when this became clear that there are a certain number of posterior fossa ependymoma patients with 1Q gain who may fail metastatically, he included a clause to consider CSI, but that was optional based on family agreement. That was not for all patients. That was still the focal radiation was still the main thing that he was doing.
The Toronto group does CSI for every single relapsed ependymoma, and they've been doing that for the last 10 years, and they don't do any focal re-irradiation for even a local failure, whether it is supratentorial, whether it is posterior fossa. Yeah. So, I mean, we have been doing focal re-irradiation for supratentorial tumors if they have local failures. For posterior fossa, we were still doing local treatment, surgery and focal re-irradiation. But when we analyzed our data, the second failure was predominantly leptomeningeal more than 60% of patients. So even if there is a local failure and there is a 1Q gain, we now offer CSI to these kids.
They offer CSI. I think they had a small number of patients that they published, isn't it, in neuro-oncology recently. I think it was about 40 patients or so, where they seem to indicate that the CSI may be beneficial. And I think that may be the future. That's what's going to happen. But I think we still need to await some more data to see if that's actually true, whether CSI will reduce, or improve outcomes. And I'm aware of that. I think Toronto even had, I think they were even considering an upfront trial, isn't it, using CSI?
Yes.
Have they started
I don't think they started that, but there was some talk around.
Yeah, some talk about using CSI upfront as well. So I think that is another thing which is being debated. But right now, it's not offered as a blanket for patients. But you're right. I think by the time they get into second and third relapse, the tumor is all over the place, especially if it's 1Q gain. So it's a fair thing. Again, might be something in the future.
If there is any, it's a bad biology, is there any role for like a medulloblastoma, high dose chemotherapy and tendon transplant?
Yeah,
Has
so
anyone
I think
tried?
the Head Start trial has looked at ependymoma, isn't it? But that was not an adjunct therapy, just as high dose chemotherapy, and that was a failure. I think most of the patients ended up getting radiation. Now, I don't know whether we'll ever have a trial where, after seeing the CNS 0831 data, where anyone will consider, adjuvant high-dose chemotherapy. I'm not sure if that's even an option. I think, some of the things, the molecular data from CNS 0831 will give us some more insight as to the biology of these tumors and which are the one that is responsive to chemotherapy. But the Head Start data using high-dose chemotherapy alone approach was at very inferior outcomes, and most of them ended up getting radiation. Again, that was not a molecular study. Who knows how many of them were PFB tumors, how many were GAP tumors, who probably would have been cured regardless, right? So I think that's where some of the limitations of those studies are.
And now when we know that these children may require repeated re-irradiation and all, do you consider now proton is going to be in vogue, I would say, in India also. So where do you select proton therapy versus, do you ever have a more inclination to give that versus the regular radiotherapy?
Yeah, and I think, Manas and I were talking about this as we were driving this morning to work. So pretty much proton has become a standard for most of the patients, except maybe, some of the high-grade glioma patients or the DIPG patients, right? Now, I think, Tejpal sir can talk about this a little bit more. But the idea is that in high-grade gliomas, especially whether it's glioblastoma or anaplastic astrocytoma, because it's expected that there's going to be some microscopic invasion beyond what you see on the MRI. So there is some merit maybe in using photon treatments as a scatter effect to cover some of this. Again, these are all theoretical probably, but as a scatter effect, you can use photon treatments. In DIPG, I think the argument is that, if it's a typical DIPG, the survival is so poor. Is there any merit in using proton radiation in these patients when you can use photon, easier to plan, easier to administer, I suppose. And most of these patients do not require sedation, I think, in our center. And so I think those are some specific instances where we have used photon, but pretty much I think everywhere else proton is replacing photon treatments, especially in ependymoma. I don't think, unless you don't have the capabilities, at least in the US, for patients with ependymomas, most of them end up getting proton radiation.
So, Santhosh, that's certainly not going to be the case in India, at least not for the next 10, maybe 20 years also. So currently the Apollo Proton Cancer Center is functional as a proton unit, and our own proton center is actually on the verge of commissioning. Probably will go clinical in the next 6 months or so. Having said that, we have taken we would be treating, of course, one of the protocols that we have submitted for when the sort of proton facility starts is in children with ependymoma, both in the newly diagnosed setting as well as the recurrent setting. I think recurrent becomes much easier. I mean, I think most re-irradiations people would prefer to do it on the proton, but I'm still not very certain whether every child with a brain tumor, including ependymoma at a newly diagnosed setting would receive proton, certainly not in the near future in India.
And I think, the question also is it necessary? As Madam pointed out, is it really necessary that everyone should undergo proton? I think one of the things is the location of the tumor, isn't it? Especially if some of these patients are going to undergo re-radiation. If it's a vital center like the brainstem, and then you have administered proton up front, and then at re-radiation also you're going to use proton, you're at a considerable risk of radiation-related changes. And I myself have patients in my clinic that I follow for radiation necrosis, Avastin. We use Avastin and steroids. I think there are a lot of factors that needs to be considered, and by no way I am promoting proton. I'm not saying that what needs to be done, or somebody who doesn't get proton is at a disadvantage. That's certainly not the case. I'm just explaining. I'm just giving you an insight about what the situation is in the United States, but not necessarily. I don't think everybody agrees that's the right thing to do. You have an equally good outcome with photon, and maybe even some of the side effects are probably, the risk of side effects are lesser with photon as compared to proton. So I think it ultimately depends upon more data and availability.
In posterior fossa tumor, where it goes through the foramen into the upper cervical canal, is there any, does it have more propensity for spinal mets, drop metastasis, and there is a case for craniospinal in these situations whenever it escapes?
No, I think, I brought this up with the trainees this morning, that sometimes in ependymoma has a tongue-like projection into the cervicomedullary junction and extends to that. But even with that, the drop metastasis is so rare in these patients. I don't think they can make a case for CSI in these patients. I mean, I think one of the things that we hear from our radiation oncology team is, how nervous they become when the area of the brain and spinal cord that has to be radiated, especially around the foramen magnum, that if they end up having some radiation-related changes, necrosis especially, they could get symptomatic pretty quickly. And sometimes we tend to follow these patients a little bit closer than other patients to pick up any asymptomatic radiation-related changes so that we can treat them immediately. But otherwise, I don't think there is any role for CSI yet.
But do you cover how you have your tumor volume? Do you cover the upper cervical spines? How does it go? I'm curious to know that.
So, ma'am, the resected tumor bed with a margin, I think St. Jude's uses a 0.5 centimeter margin. At Tata Hospital, we use a 1 centimeter margin. I mean, I think as you sort of gain experience, you tend to reduce your margins. So previously, I think St. Jude's, Dr. Merchant also used a 1 centimeter margin. Now everything is 0.5 cm in St. Jude's, but we still use a 1 centimeter margin at Tata Hospital.
That is correct. We limited it to 5 millimeters, half a centimeter margins. The same thing with medulloblastoma as well. So other than that, I think the practice is pretty standard to do focal radiation treatment.
So we reduce the dose in tumors that are extending downwards onto the cervical spinal cord. We give them 55.8 gray rather than the 59.4 gray. Yeah. I think with protons, you could actually give the 59.4 also without really causing too much of, although the risk of brainstem necrosis because of the lateral penumbra and range uncertainty actually increases with the proton beams.
Yeah, so I do have a question about that. I mean, I think, I think a lot of centers are discussing the possibility of limiting it to 54, isn't it? So is that something that you see with that will happen?
So I think I think some of the data of dose escalation is not very encouraging, and we really don't know what is the real dose response relationship between the 54 to 60 gray sort of range. But in supratentorial, we would always want to give 59.4 gray. In infratentorial, particularly in young children and close to the spinal cord beaking down, we do restrict it. 54, for all you know, 54 gray might also be sufficient. We really don't know the exact dose response relationship.
Yeah, and I know there are certain exceptions to that rule, but I think for most part, I think Dr. Merchant has been restricting to 54 or 55, a little over 55, but I do know that sometimes he talks about giving higher dose of radiation. So I guess it's patient dependent as well.
So I just had one last question to Santhosh, because I don't think any neuro-oncology talk can be over without talking about late effects. And if we can just mention very briefly that, we irradiate these young children with ependymoma, giving them focal RT. Do you see a lot of late effects in these children? And is that a major disability to them if they get focal radiation?
Yeah, I think regardless, I think despite the aspect of focal radiation right now, of course, we don't know what will happen now that we have proton treatments. The expectation is that the side effects are going to be less. And I think we're already starting to see that, not every patient ends up with having some endocrine issues. But yes, that is something that needs to be considered even in posterior fossa tumors, that photon radiation that these patients have received is expected to produce some amount of neurocognitive dysfunction, and also can cause endocrine deficits because sometimes the axis can be involved in the radiation field. And not to, of course, in supratentorial, it is almost certain that some of these patients will get neurocognitive dysfunction. However, how much of it is because of pre-existing tumor and hydrocephalus, we can never say, because some amount of damage may have happened from the tumor itself. But yes, all these patients, especially if the extension into the cervical medullary junction, please be very careful. These patients end up with pretty significant kyphosis and due to the tumor and surgical intervention. And I've had patients who come in with compressive spinal cord symptoms. So yes, late effects are absolutely something that we need to watch. Not to mention the vasculitis and vasculopathies, which can happen with the radiation. And now if you're going to start combining it with chemotherapy, I think we all better watch out for hearing loss and problems with hearing, which could handicap some of the language development in these patients. So even with focal radiation and 4 cycles of chemotherapy, I think these patients need good long-term follow-up.
Manas, I would just want to add there that you wouldn't have really long-term survivors if you didn't give the radiation. So, I mean, because they are living.
It's just to make all of us aware that is something
to be followed.
Yeah, of course. I mean, as radiation oncologists, we even giving 1 gray or 2 gray of radiation can cause a lot of problems.
We irradiate everyone, sir.
That is my favorite. That
happens to all ependymoma.
Actually, that is my favorite quote for using CSI in more than 3-year-olds, ATRT patients more than 3-year-olds. When people say, okay, CSI can cause problems, and I'm like, okay, well, ATRT is such an aggressive tumor that you may not have a living child to follow up on neurocognitive effects if you don't optimize treatment. So that's actually my favorite quote for ATRT patients.
So thank you, Santhosh, for a wonderful presentation. Thank you, Poorna ma'am, Dr. Tejpal, and everyone else who joined us. Thank you, PHO chapter. Thank you, ISNO. And thank you, Gangaram Hospital, for helping us organize this.
Yeah, and I just want to end by thanking Manas, all of you all for attending, and also for Amar Gajar, who most of you all know. He's been a really good mentor and has been encouraging me with everything. So thanks to him as well.
Okay.
Thank you.
Thank you.
Bye.
Okay,
bye. Bye.
Thank you.